Order. I call this meeting to order. This is a standing committee on health. I'm John A. McDonald, the MLA for Hants East and the chair of the committee. Today we will hear from witnesses regarding links between health outcomes and lack of safe, affordable housing. As a reminder, please ensure all your phones are on silent. I'll now ask the committee members to introduce themselves for the record by saying their name and constituency. And I will start to my left for his first ever committee meeting since being elected as an MLA, to Mr. McLeod.
Good afternoon, everyone. Marco McLeod, Pictou West.
Welcome.
Good afternoon, Chris Palmer, MLA for Kings West. Great.
Good afternoon, I'm John White, MLA for Glace Bay and Dominion.
Yeah, hi, how's everyone doing? Nolan Young, MLA Shelburne.
Hi everyone, I'm Sue LeBlanc. I'm the MLA for Dartmouth North.
I'm Gary Burrow, the MLA for Halifax, Chebucto, and we, the NDP, would also like to welcome Marco to the legislature.
Thank you, and welcome to the guest and Marco. Rafa Di Costanzo, MLA Clayton Park West.
Good afternoon, everybody. I'm Braden Clark, MLA for Bedford South.
Okay, for the purpose of answers, I'd like to recognize the President of Legislative Council, Gordon Hebb, to my left, and Legislative Committee Clerk Judy Kavanaugh on my right. Okay, so we'll start at first with just having the witnesses introduce themselves and who they are, and then I'll come back for opening remarks, and I'll start with Ms. Knight.
Thank you. My name is Joy Knight. I'm the Senior Executive Director of System Integration at the Department of Health and Wellness.
Yep, it's leaving.
Oh, sorry.
They're good. They'll go all the way across from me.
Yeah, I didn't see the light. Sorry. I'm Suzanne Lee. I'm the Executive Director of Employment Supports and Income Assistance at the Department of Community Services.
Hi, Tatiana Morren-Fraser, Executive Director of Housing Strategy and Analytics, Municipal Affairs and Housing.
I'm Marie-France LeBlanc. I'm the CEO of the North End Community Health Center.
Hello, I'm Sheri Lecker, Executive Director of Adsum for Women and Children.
Thank you. So we'll start with opening remarks, and I believe I'm going to start with Ms. Knight first. So, Ms. Knight.
Thank you, and thank you everyone for the invitation to be here today. I'm really looking forward to discussing this important topic with you. As I've said, I'm the Senior Executive Director of the System Integration Team, and I think that's really important to highlight because what I want to focus on my brief opening remarks is the importance of system integration, and one of the reasons I'm happy to be here with all my colleagues across departments as well as within community. I want to quickly thank Ms. Lecker, Ms. LeBlanc for the incredible work that they do every single day and the valuable partnerships that we hold with them. As you are aware, the healthcare system is complex and interconnected, and issues in one area often have a root cause in another. In my role in the department, I work with partners at the health authorities, across government departments, and with community to look at the system as a whole. Our work has to be integrated in order to advance improvements across the social determinants of health. Action for Health isn't just focused on modernizing our facilities and recruiting healthcare workers that we need. It also includes improving equitable access to care in ways that are trauma-informed, empathetic, and meet people where they are. A great example of this is our partnership with the Department of Community Services at the Bridge, led by Adsum for Women and Children and Welcome Housing, which we'll talk more about today, I'm sure, and with the North End Community Health Center for delivering clinical services to vulnerable populations and outreach through the Mobile Outreach Street Health Team. Another example of how we are thinking differently and about how care is accessed within Nova Scotia is through the health home and health neighbourhood model. Health homes are made up of teams of healthcare professionals, like doctors, nurses, nurse practitioners, who work together collaboratively to help bring the expertise and knowledge to the table to provide the care that patients need. They connect with other health services in the community, like pharmacies and occupational therapy, to link patients to the full scope of services they require. And down the road, we look forward to implementing health neighborhoods that will eventually encompass the network of healthcare allies and providers that exist within community. The neighborhood model recognizes that we must consider all aspects of a person's life, including housing, income, food security, and culture in order to meaningfully address a person's well-being. Health homes and health neighborhoods will take the burden of system navigation off of the patient so that they are directed to and supported with the right services they need. This is a critical part of Action for Health work because, as I mentioned previously, issues in one area often impact another. If people are not receiving the right care in the right place, we can see delays across the system. Moving people through the system as smoothly as possible helps everyone. It keeps ambulances on the road by reducing offload times. It frees up emergency departments for those who need the most urgent and acute care. And it moves people out of hospital beds and back into community with the services they need tailored to match their needs within their community. Further, as we look collectively beyond the traditional borders of the healthcare system, we identify other areas where access and flow barriers are keeping people from accessing the care that they deserve. That is why it is so important for us to continue to work closely with our colleagues in other departments to ensure a holistic approach to healthcare in Nova Scotia. Again, I'm very pleased to be here today, and I look forward to your questions. Thank you.
Thank you. And next, Ms. Lee.
Thank you. Good afternoon, everyone, and thanks for the opportunity for me to join you today to talk about this really important topic. So I'm here, as I mentioned earlier, on behalf of the Department of Community Services, and with my government colleagues at the table here from Health and Municipal Affairs and Housing work more directly on the topics of affordable housing and health outcomes, which is the topic of why we're gathering today. My team at DCS works with a range of partners, including all of those at the table today, in community, across government, and beyond, to address homelessness in our province. We work together to ensure that our response is comprehensive, that our solutions are thoughtful and sustainable, that we evolve as the context changes and we learn new things, and that people, families, and communities remain at the center of all of the work that we do. And we know we need many hands to do this work, not necessarily as a way to lighten the load. I think all of my friends at this table would agree that there is nothing light about this work, but we need everybody at the table working on solutions with us. It really is the only way. And so while I'm here representing DCS, we have a small but very mighty team back at the office who are working away. Some of them may be watching. They work around the clock many days with our partners. They're passionate and driven, and really are a true testament of what I value in the public service. And so a little thank you to them while I'm representing their work. I'd also like to recognize the work of our service providers. So we have two fabulous examples here with us today at the North End Community Health Centre in Adsum. And you know, at DCS, we know we're not on the front lines. We're not the experts. Our colleagues at the table here are, and we really couldn't do any of the work that we do without their support. They have the experience, they have the expertise, and most importantly, they have the trust and confidence of the community that we serve. And so with people like Sheri and Morren-Fraser and a range of many other service providers on the ground, government has been able to increase the budget for homelessness by 360% over the last 3 years, create more than 600 supportive housing units, we've added 195 shelter beds, and we've opened 19 new shelter village units in Lower Sackville, with another 96 open in 3 more locations in the next few weeks, and 85 more coming online later this fall, and creating space for 70 people in 60 new tiny homes. We've also been able to, again, with the support of our partners, provide $2 million to support Nova Scotians with diversion funding, $1.6 million for street outreach teams in HRM, CBRM, and Truro, and the addition of 24 housing support workers in our province. And I'll end by saying we learn more every day that we do this work, especially from our partners on the front line, and that's a really key tenement in the work that we do in making sure that we evolve with the context. So I'm looking forward to the conversation. I'm looking forward to hearing from them as we answer your questions today. Thank you.
Thank you. And Ms. LeBlanc.
Thank you.
Ms. LeBlanc. Thank you.
Thank you for inviting the North End Community Health Centre here today. At NECHC, we believe homelessness is not merely a housing issue. It's fundamentally a health issue. The absence of stable housing affects every aspect of a person's life, from physical and mental health to social and economic well-being. At the North End Community Health Centre, we witness that firsthand how homelessness exacerbates challenges like chronic illness, mental health disorders, and addiction. This is why we approach all of our supportive housing through the lens of health, not simply as a shelter, but as a foundation for recovery, stability, and hope. For over 50 years, 53 to be exact, the North End Community Health Centre has been providing a wide range of supports to those experiencing deep poverty and hopelessness. We began as a collaborative primary health care clinic in 1972, and over the years we expanded our offerings to include a free dental clinic, a mobile outreach street health team, which most people know as MOSH, a Housing First program, a managed alcohol program, a pause mental health walk-in clinic, and now 16 supported housing buildings across HRM that permanently house and support over 200 individuals who were previously experiencing chronic homelessness. And I'm going to repeat, permanently. These people have leases. This is their home. They are there until they choose to leave. This is what NECHC and not-for-profits do. We identify gaps in services within our community and figure out how best to fill them. NECHC is more than just a healthcare provider. We're a cornerstone of support for HRM's most vulnerable. Our services are comprehensive, addressing not only physical health, but also the social determinants of health that so profoundly impact people's lives. We provide housing and healthcare within an integrated model, which meets people where they are, with compassion and without judgment. Our harm reduction services are a key part of our approach, including the provisions of safe supplies for those struggling with addiction. The most obvious example of the comprehensive approach is the Overlook, a supportive housing initiative that you've probably heard about that has provided a lifeline for many who've experienced chronic homelessness. The Overlook doesn't just offer a roof over someone's head. It provides a comprehensive support system that includes mental health care, addiction services, a dispensary, which is sort of like a pharmacy, managed alcohol, safe supply, primary care, cultural supports, which are key, and other essential health supports. It's a model that recognizes that housing is health and that without stable housing, other interventions cannot succeed. The success stories emerging from the Overlook are as varied as the residents themselves. For some, success means remaining housed and receiving the supports we offer, an achievement that is no small feat in and of itself. But for another resident over the last few months, success has meant stabilization in their addiction, graduating from our peer support program, which we run at the Overlook, and moving out of the Overlook and into one of our other houses, which has less supports, as a live-in peer support worker. He is now the support for other individuals. And yet for another tenant in the last couple of months, success has meant working through their addiction, becoming sober, and independently moving into their own apartment outside of the Overlook. They're still attached to us through our clinic and through MOSH, but they are now independently living. So without this supported housing, none of this would have been possible. And these are the words of one of our residents. The Overlook has given me the opportunity to think and redirect my future. It's keeping me safe and physically housed. Basically, they treat me like a human. That's pretty awesome. I've got a sense of pride now. I can choose to get help, and I didn't have any choice before. Having choices is important. My eyes have been open. If I wasn't at the Overlook, I wouldn't remember what it feels like to have hopes and dreams again. Choices. That's really key. That's what everybody needs and deserves. At NECHC, we provide supportive housing that ranges from minimal supports to 24/7 care. All are needed when looking at providing housing for those experiencing homelessness, as no two people are the same, and neither are their needs. As health and housing service providers, it's our mandate to provide the appropriate services to our community. But to continue this vital work, we need cohesive, reliable funding that allows us to expand and sustain our programs. Our funding for all of our NECHC programs comes from 30 different contracts from a variety of government departments, both federal and provincial, as well as private grants. This lack of cohesiveness in funding forces us, as a not-for-profit organization, to constantly fill financial gaps. Instead of focusing solely on delivering and expanding services to meet the growing needs of our community, we are often caught up in the struggles to piece together the necessary funds to keep our programs and organizations running. This fragmented approach to funding not only threatens the sustainability of our programs, but also limits our ability to scale up initiatives that are clearly working. 5 years ago, NECHC had 28 employees. Today, we have closer to 180 staff. I still do not have any core funding. Managing this on project funding that never quite covers costs is not sustainable. We are the solution. We've been doing health home and health neighborhoods for 50 years. This is not new. We've been doing it. We are a very real solution to a real problem in our city and province. And in order to continue our work, we need our government partners to invest in us and the communities we serve appropriately. Thank you.
Thank you. Ms. Lecker.
Good afternoon, and thank you for the opportunity to speak with you today. For more than 20 years, I have served as the Executive Director of Adsum for Women and Children. Currently, Adsum is supporting approximately 200 people with emergency shelter. More than 100 people have safe, affordable, permanent housing in properties owned by Adsum throughout the Halifax Regional Municipality. With shelters and housing full, we are supporting another 315 people in hotels, campsites, couch surfing, or in emergency units, including 197 children. This program is at capacity, and we are forced to turn away people, individuals and families with children multiple times every day. We know that secure housing leads to improved health outcomes. We have witnessed this time and time again with the people we meet. Just last week, I ran into a tenant who had been living in our building that we own for almost 13 years. She gave me permission to share this story. Prior to being housed with Adsum, her health was extremely unstable at times. At times, she was using emergency health services multiple times a month. Since signing a lease and settling into her place, she has not called upon emergency services for her mental health in almost 13 years. In her words, housing coupled with appropriate support created a miracle in her life. We have other tenants who, once they are housed, may continue to struggle for a while, but ultimately achieve improved health because of the stability of their housing. I recall someone, it took us 5 years. She and I think back on it now. It took 5 years to attain the level of stability that we talk about so that people could feel that sense of permanence. Conversely, and tragically, we know too well the catastrophic health outcomes of not having housing security. Without a secure place to call home, a person's health suffers. Their life is shorter, and in too many cases, is not afforded the dignity we all deserve. We have lost so many clients and community members prematurely. In addition to the negative health outcomes of those experiencing housing insecurity, what isn't often talked about is the indirect impact of homelessness on the health of support workers and service providers. As an employer of almost 200 staff, I am seeing the toll this crisis is having on my employees. The moral injury inflicted on a person is indescribable when the best that we can offer a mom calling or an individual at the door is a tent. The negative impacts of the housing crisis are far-reaching, and we are doing the best we can to fill the gaps until everyone's rights to housing and dignity are realized. I'm pleased to take any questions you have about what we are witnessing and what our clients have shared with us. Thank you.
Thank you. So as this committee goes into 20 minutes, then we'll wrap it up. I'll split it up at the end. At 20 minutes, I'll have to say order, sorry. Very first will be MLA Di Costanzo for the Liberal Party. MLA Di Costanzo.
Thank you, Chair. And thank you, Marie and LeBlanc and Sheri for... I had my own questions, but honestly what you just said has changed where I'm starting. And I just want to commend the North Health Center because I knew about it when I was a medical interpreter and worked with the refugee clinic. A lot of the doctors worked in both, and they would know so much about the social aspects and help the patient with housing, with issues, and she would say, "Oh, we got this from the North End because you're dealing with it day in and day out." So it wasn't just the medical, the health. And I remember thinking, well, they need a social worker at the refugee clinic just to look after that. And I know that your model has been successful, as you said, and it's known. And the only other one that I know of is in Clare. There's another, what I call collaborative care. Now they're calling it home care, or they're moving it to a neighborhood care. You have proven that your services are the best way to handle healthcare. How many more healthcares like yours have opened in the last 3 years? Have we moved? Have you helped other organizations or groups of doctors to establish what you have established? Have we seen any movement towards the success that you have been doing?
Ms. LeBlanc.
So I happen to be the chair of the board of the Nova Scotia Association of Community Health Centres as well. There are 8 of us. We are as different as it can be. I appreciate that you mentioned Clare. Clare is completely funded by the city. The city owns the building, the city pays for all their core funding, and now they also have core funding through NSH. We are incredibly unique in that we're not like that. We receive different pots of money from different, but we are managed by a board of directors, and we employ all of our own employees. This is what allows us to pivot. This is what allows us to be able to figure out what the gaps are and to move quickly, which is something that's very difficult to do in a big establishment. But when you have people that are experiencing homelessness and the crises that they have, they don't have time to wait 4 months for us to go find them housing. You know, we get a lot of calls for empty buildings, and we can move on it quickly, or we could move on it quickly. It's getting more and more difficult. So to answer your question, I don't believe there's anyone else like us. In Cape Breton, the Alley Centre is moving towards that, but they're having all the same growing pains that we had 50 years ago, and that we still continue to have. There is no core funding. They started as a shelter and are moving towards healthcare. We started as healthcare. We do not do shelter. We moved to housing. So it is a model that works. It's a model that works across the country. It is not a model that has been adopted here yet. I understand that there's the neighborhood, the health neighborhoods that are being contemplated. Those will be NSH-run organizations that will not allow for the pivoting that is necessary when you're dealing with the most vulnerable. It's very good in a lot of areas, but when you're dealing with the most vulnerable, as we've seen, it's a lot of work. It can take 5, 10 years to help a particular family or a particular patient. Hospital system, public sector does not have time to do that. That's why we do it. But we're not appropriately funded for it. If we're going to be a solution to a problem, which we've been counted on for the last 3 years, we really need to step up and allow these organizations to be properly funded. For me, not to have $800,000 of fundraised money from last year in my budget just to make ends meet and still tell my staff that I don't have enough money to help more people. We need to be able to provide the appropriate services and have a system and a consolidated way that I don't have to go to health because I need a nurse for something that's happening in housing. It just doesn't make any sense.
MLA Di Costanzo.
Thank you. Thank you for explaining that. I also want to know, how are you keeping statistics of the increase in the number? I know, honestly, I remember when I was first elected in 2017, I had a young guy. That's the first time when I heard about homelessness, because in Halifax we would see 1 or 2, if that. I never remember seeing tents in 2017 at that time. So this young guy who was at university came to me, and he wanted, apparently he and 2 other university students would go and make sandwiches out of their own money and go sit with the homeless and treat them like human beings and connect with them. And so I helped him. I said, this is fantastic. It's a beautiful thing. He opened an organization, called it Greater Love, and I helped him how to establish a nonprofit so we can get him some funding. And that blew up within 2 years into 70 university students, and they would go and help the homeless. That's when I started getting interested to hear from him. And at the time, I remember asking him, so how many people are you seeing? And he said 17 to 20. Okay? How did we go from 17 to 20, this is just HRM, or just maybe downtown with all these tents, to over 1,000, 1,200. In the last 3 years, in particular, it has tripled. So how are you keeping track of statistics and how much cost that has been to the health system and what you're trying to do?
So, MLA Di Costanzo, who are you directing that to? I just want to make sure.
I believe Marie and maybe...
Ms. LeBlanc.
Sorry. Oh. I'm
So I'll start with Ms. LeBlanc.
Ms. LeBlanc, I'm sorry.
Well, I think actually Sheri and Joy might be better served to this. What I'll say from our perspective is that it was never 17. We've been around for 52 years. If it was only 17 people, we wouldn't have survived 52 years. It's been hundreds, and it's been hundreds for a long time. And it's been a variety of different ways to track homelessness. It's been couch surfing. It's been insecurely housed. It's been people living outdoors. It's been people living in shelters. And I would respectfully say that the numbers that are being touted through the by name list don't represent half of what we're seeing. So in terms of statistics, we keep our statistics through the patients that we see, through the people our MOSH team sees, through the people that our housing support team see. We work with all of our community partners and with community services and to keep track of it. But like I would say, it's an overwhelming problem that statistics are not doing justice. I don't know if Sheri, you want to add to that?
So, Emily Di Costanzo, you want Ms. Lecker and then Ms.
Yes,
Okay.
I would like that, and I apologize.
No, no worries.
May I just add one
Okay.
thing? I
Emily
apologize
DeSantis.
for the 17 or 18. They were just they were on the street, not all. That's what that he was dealing with. Sorry.
I'm gonna go to Ms. Lecker and Ms. Lecker.
Okay, thank you. So, as Marie-France mentioned, there have always been much larger numbers, and I appreciate that you're referring to 17 related to this one student who you came in contact with. But similarly, we have been operating for more than 40 years, an emergency shelter. We built housing 37 years ago that is affordable as an alternative to people who had nowhere to live. We have built multiple other locations and purchased and so on. And we're not the only organization in town. So there have always been large numbers. I think what people are noticing more, of course, is what is called visible homelessness. You're noticing that people are tenting. But there has always been, and there continues to be, a very, very large number of people who are considered hidden homeless or invisible. They're on sofas. They're, maybe in someone's backyard, or they're in someone's driveway in a mobile home or in a trailer. COVID, of course, exacerbated things, but so did so did the economy, so did the cost of renting, so did the gap between what people are receiving and what they need to pay for rent and food and other things. So what you're seeing is visible homelessness. There's also invisible homelessness, and that would include university students who don't move out. They maybe even graduate and they're still living in the basement or in their childhood home because they can't afford to move out. They are actually hidden homeless. They can't afford to live somewhere else. So the numbers have always been there. They have absolutely expanded. They've really exploded since COVID because there were reasons why people were turfed out if they were staying on someone's sofa. Family members were coming back from other provinces, or people were afraid to have non-family members in the space. So there are all of those reasons. We keep statistics, and there is also something called a by name list that is managed by AHANS, the Affordable Housing Association of Nova Scotia. And they, if you care to look on their website, I think they publish the numbers every Tuesday. I would caution that those numbers, they're not the full picture. They don't represent everyone who's experiencing hidden homelessness or invisible homelessness. They also don't count children, which we are encouraging them to do. We count children, and we have reached out to other organizations that are working with families to count children. There are 197 children today who are not in stable housing, not counting all the other mothers and all the other families that are calling us today with nowhere to go. So even the by name list, which is probably the most robust number we have, as robust as it can be, is not the full picture. And I think that, you know, particularly in Halifax, but certainly I'm hearing this across the province. I've been home to Cape Breton. We are seeing people in tents. We're seeing people staying in places where we're not used to. But there have always been some people tenting. It's just that now I'm afraid that it's become normalized, to be honest.
So I'm going to allow Ms. LeBlanc to do the quick comment you wanted, and then I'll get to Ms. Joyce. So.
No, I think
it's.
Sorry,
Okay.
I think Sheri mentioned it. I was just going to explain the by name list.
Okay.
So I think we're good.
Perfect.
Thank you.
Ms. Joyce, or sorry, Ms. Knight. See what you made me do?
Thank you very much. And I'll acknowledge as well that access to data is a real problem, and it's something that we have to be much more focused on and will be more focused on. And needing to have partnerships with other departments is critical in that, because we have shared services, shared programming, shared outcomes, and if we work better together, we'll have stronger, more meaningful data to help inform the decisions we want to bring forward for government consideration. So there's a gap there. We recognize it, call it out, and we know we have to do better in that space. I'll also mention, though, that it's important that we look beyond our traditional idea of where we access and pull data, and we have conversations with community around what the data they're pulling. So some good examples would be great conversations we're having with Dudjagamic around what their healthcare needs look like and the data that they're able to provide. Thinking about it both quantitatively and qualitatively. And then some great conversations we're having with the Brotherhood and the Sisterhood around the impacts, particularly of homelessness on the African Nova Scotian community. And so we need to make sure we understand the equity lens when we're looking at our data and where those gaps don't exist in our data systems and how we access that. We do have some statistics from an emergency department perspective. We are required to collect that data. And so that is information I'd be happy to share with the committee. But it helps us to start to see patterns and to be able to respond more meaningfully. So while we need more, particularly in the primary healthcare space, and maybe I'll let Ms. Lecker speak a little bit more about the bridge outcomes when the time is right. But it helps us to see just from who's showing up at the emergency department, that they have a longer length of stay there and that their costs are higher than an average emergency department visit. So you can start to see what those impacts are. And there's the moral imperative that Ms. Lecker spoke about. And then, of course, there's the system imperative of you want to make sure you have the right services for people, because the emergency department is not the right place for a lot of people experiencing homelessness. And they're not getting the right care that they need there. So there's already information in the data, but we know we have a lot more to do to get the data we need.
MLA Costanzo. 6.5 minutes.
Thank you. I'm glad you mentioned the data that was two other questions that I was hoping is, what is the cost of the homeless? I assume when you said data, you ask the person what their home address, and they say, I don't have an address, and you have a list of those who are showing up at emergency who are homeless. Is that correct? Is that what I understood when you said we have that data from emergency departments?
Ms. Knight.
Do you know how many homeless
sorry.
people are showing up at emergency, and what is the cost? If you can give us those figures, that'd be great.
So, Ms. Knight.
Thank you. Yeah, there's standardized reporting across the country related to that. And I do know that, excuse me, as I look at my notes, from 2018 to 2023, an increase from 73 people to 147. Annually, it's doubled. And then we have an average cost of roughly double. It's roughly double the cost from an average Nova Scotian to somebody who's experiencing homelessness, 10,000 roughly to 20,000.
MLA Costanzo.
I just want to understand what you just gave me. So there is only 147 people who are showing up at emergency that are saying that they're homeless, and the cost is because they've been sick for a while, or what? The double, what does that mean? Is it because they're more severe, or because they're staying longer? How do you say double? What does it mean?
Ms. Knight.
I'm sure that there's be a number of circumstances that would make the costs higher. Likely they haven't accessed health care in some time, more complicated co-trimorbidities involved, and likely need a longer length of stay to support them to fully address their needs. And so the data that I have says that they tend to have 3 times the length of stay than the average Nova Scotian, and the costs are double with respect to the care the patient requires.
MLA Di Costanzo.
And if I may ask as well, how many of them have no family doctor of the homeless people?
Ms. Knight.
Thank you for that question. Unfortunately, I don't know how many are unattached to a family physician. I've anecdotally from service providers heard that a large proportion are not attached, but I also recognize that typically a family practice is not always the most supportive environment for people experiencing homelessness, or the most accessible type of an environment, and that's why it's so important that we have services that are meeting people where they are.
Emily Di Costanzo, 3.5 minutes.
And maybe this is the last question for this round. How many of those people that are without family doctor that you have on the list are sorry, I lost my thought here. How many of the homeless who have no family doctors, and what is the consequences of that, and how do they receive their medical information? How are you dealing with that? If they have no family doctor, when they are released, how do you send the information if there's a follow-up?
Ms. Knight.
Thank you. I know that the MOSH team has records, and they're able to follow the care of a patient they're working with. So perhaps, Ms. LeBlanc, you want to speak to that. But you are correct in that not everybody does have that access. And so that's why it's critical that we continue to work really closely around how we get that outreach and those services. But also recognizing the health system has to think differently about what it looks like to do discharge planning for individuals, and be more coordinated and integrated across our departments, so that when we are discharge planning with an individual, we're connecting them in with services that Ms. Lee is able to offer, or into supportive housing, or ensuring there's that smooth transition in place.
So, Emily Di Costanzo, do you want to hear from Ms. LeBlanc?
Sure.
Ms. LeBlanc.
So we have the Mobile Outreach Street Health Program, which supports individuals that are unhoused or living on the street. We have rostered and unrostered 1,979 people with MOSH. They're insecurely housed. They might be in a shelter. They might be temporarily housed or coming out, or they might be transitioning to our clinic. Because once they get housed, permanently housed, they transition to our clinic. But when you ask about when they get released, more than likely they're being released to MOSH. Their records are being released to MOSH or to our clinic, and then we try to follow up. A lot of the times there's and Sheri will be speaking to the bridge. Now, if they need to be released to somewhere where there's more supports, we do have a location if they qualify for there. But a lot of the time, if they're being released and they have nowhere to go, we try to keep following up with them as we move along. So 1,979 are rostered and unrostered on our MOSH patient list. And we have 3 physicians, which is really only 1.2 FTE for that number of patients, and a nurse practitioner. And a lot of nurses and social workers and other staff. But.
Emily Di Costanzo, 34 seconds.
Oh, I would just say thank you, but I think I remembered also my question is, when we're taking numbers of people who are without family doctor, are you asking that if they are homeless or not? Do we take that data in? Yes or no?
Ms. Knight.
If I understand the question correctly, is it when we ask from the Need a Family Practice Registry, if that question is asked?
Yes.
To my knowledge, you have to provide your address. So if you don't have an address to provide, I'm actually not sure how it is captured in the system. I would have to look into how that's categorized, but it's not a category we pull information on now.
Order. Next will be Emily LeBlanc.
Thank you very much. I'll just start by saying that I represent a community in which many of your programs and or your services are deeply embedded, and so I am very grateful to you and all the people that work for you and with you for the work that's being done in Dartmouth North. It feels like things are spiraling out of control, and every day, people in my office spend a good portion of their day on the phone with people in your offices for, assisting people who are walking in or people who are, long-term clients of ours, and so, and I have never seen it so out of control, basically, and it's troubling and upsetting. And I want it to stop. I want things to be better. And so I guess my first question is, so like when I was elected in 2017, like I remember going to meetings about, people like unhoused people living in tents. I remember a big meeting that we had, out of that came like an unfortunate homeless shelter for a while. And, this was like at the beginning of my political time. But anyway, the point is that it's a lot different now. And the by name list, which is not accurate, like says that there's something like 1,300 people on it, but we're hearing that it's not totally accurate because it doesn't list children, and there's a number of people who we don't know about. So the question is for Ms. LeBlanc and Ms. Lecker is, in your mind, why is the problem getting worse and worse?
Who do you want? Oh, it looks like Ms. Lecker. I see Ms. LeBlanc point to her. So Ms. Lecker, you'll get the first one.
Okay. Thank you for the question. I think, first of all, we have to look at what some of the pathways are into homelessness or into an experience of not being housed. So there are some pathways that could be closed. And until they're closed, we are going to continue to see people who experience what we call rent-evictions or evictions. And a great many people are losing their housing due to fixed-term leases. So we have to acknowledge that. Those are policies that could be addressed. They're pathways. So if you are on a fixed income, if you're a senior, if you've never experienced a problem with housing in your past, any housing insecurity, and the building is sold, or the landlord says you're renting and the landlord says I'm moving in my daughter, or whether that happens or not, and sometimes it does and many times it does not, but if those things happen, you lose your housing, and it may be your first experience ever. And we are hearing about it from across the province, and we're certainly hearing about it from people every day. It is their first experience. So that's one thing. So that's one of the reasons, rent evictions and fixed-term leases. And there are other ways to deal with those policies, and other jurisdictions have chosen other ways to address both of those issues. We have to also look at other reasons why people, more and more people, they're struggling under the weight of a very small amount of money and their growing needs to cover the cost of food and the cost of their housing and the cost of raising their children if they have any, and the cost of paying their power bills, which continue to rise. And at some point, they're bent and bent and bent, and then it breaks, right? Or there are people who are living together and they just can't, they've tried and tried, and they cannot maintain a peaceful situation. They're not all intimate partners, but there are people who co-house, and one person's not on the lease, so they lose their housing. So we have to look at the pathways, but we also have to understand that there is less and less what we call affordable housing that is available to people. We own, and we have built, and we have purchased, and we have remodeled, and we have added to our stock of affordable housing. When I talk about that, I mean rent geared to someone's income. 30% of their pre-tax household income. Our rents in our latest housing location, they range from $285 to maybe $350. That includes utilities. that kind of housing is not being created, and we have lost so much housing that was even $535 a month or $625 in your riding, for example. So when people lose their housing, there's nowhere to go to, and certainly not at the price point that I'm mentioning. You also have housing, I believe, that's at that rate. So, you know, if people don't have somewhere to go to, and more and more and more people are being kind of forced into this experience, then the numbers explode. And of course, we've talked about COVID, and we know that people are having to make really, really tough choices. And so when they lose their housing, grandma might take the child or children, but mom has to sleep outside in the driveway in a car, or maybe go to a cousin's house, or maybe go to a tent, right? This is what is happening in our communities. And so I think I forget your question, but if it's why are we seeing so much, it's because there's nowhere to turn. And until we turn off those flows, the numbers are only going to increase. I've been at it for more than 20 years in this community, and I don't want to say I have given up hope, but I do not see as enough avenues of real hope to address this until we start to talk about permanent housing that people can afford. And that's not what we see being built, and that's not what we be seeing being created or supported.
MLA LeBlanc, do you want to hear from Ms. LeBlanc?
Sure.
Ms. Law.
So the people that we house tend to be the highest acuity people in the community. And high acuity means people with the biggest mental health and addictions issues. They have to have supportive housing in order to remain housed. When we started our Housing First program 8 years ago, we had private developers as our partners, and all of them were housed in these private developers. However, the cranes got on into the street and everything's been renovated and there's no longer any housing for us. So we have slowly been purchasing houses ourselves in order to be able to house our individuals. It's a very expensive proposition. Not only is real estate in Halifax very expensive, but the maintenance of these properties is very expensive. People who we support might leave the tap on and flood a unit just because they forgot. The damages on a monthly basis are quite significant, but they are remaining housed. And when you look at the cost of not having them housed, it's not significant. It's just a different way of dealing with it. So for us, there are more people. There's, for all of the various reasons that we're hearing across the country, mental health, addictions issues. But there's also fewer places for us to be able to house these people that are not our own spaces, because landlords don't want to be the people. They're not equipped to be the people to do that. We are equipped to be able to do that. So we're slowly adding. We've got some partners that allow us to master lease. So probably 6 of our buildings are master leased, where we take control of the building and house the people. We're responsible for making sure that the building remains in a space. Most of those buildings are earmarked for development down the road, but these developers have been kind enough. There aren't many of them, but there are a couple that are still willing to do that. So that's why we're seeing more and more. We have right now the opportunity to add 62 units if we had the funding for it. We have private people coming to us and saying, we'll sell it to you, but it takes so long that by the time we turn ourselves around, we're not able to. There's a lot of good reasons for why it takes long, but that's just the reality of the situations. If we were able to figure out a strategy, if we were able to stick to our strategy and move forward and say, we can predict that we're going to need X number of units for what we do. We can predict that we need X number of units for what Sheri does, for what all the others, and just stick to our plan. That'd be a great first step.
Emily LeBlanc.
Thank you very much. There's a lot in both of those answers. I could just speak to this, but keep going on this track for a long time. But I guess, I have so many questions, but basically they've all been addressed already. So we know that the situation's bad. We know that it's getting worse unless we turn off those pathways or close off those pathways to homelessness. We know that an organization like North End Community Health Centre is doing such incredible work on a shoestring. Like the idea that you have 30 different sources to make up your revenue is just beyond. Like, I just cannot believe it. And it is absolutely, like, I just can't even imagine how you do it. I remember having meetings with you and you were like, well, we could use this pot of money and we could use this pot of money. And it just seems completely unsustainable, but I guess, so given all of that, my question is for Ms. Knight and Ms. Lee, and I guess Ms. Morren-Fraser as well, like, where are we at with policy conversations about giving real sustainable funding to Adsum, to North End Community Health Centre, to the organizations who we call partners? I hear it time and again at public accounts and at health committee where we talk about our community partners. But if they're constantly having to run on the hamster wheel to find funding, then it's not really a partnership. So where are we with that policy conversation? And when will we see these important organizations getting stable core funding?
Okay, so she mentioned all three, so which one of you three want to do it?
Ms. Lee, or Ms. Knight.
Ms. Knight, I
Ms.
guess.
Lee.
Okay, Ms. Knight, let's start with you, and you're going to tell me who's going to be other than you.
Thank you for the question. One of the key drivers, actually, why I made a shift within the civil service to come over to the Department of Health and Wellness was my experiences when I was at the Department of Community Services with the challenges with advocating and pushing forward on this issue within this department. And so I'm really, really pleased to be in this seat as somebody who wants to champion this issue within the Department of Health and Wellness. And so bringing that moral imperative of my own to this work has already established for the first time in many ways and what we're hoping is a new way of working across the system. And it's, we're in our early days, but as part of that, we recognize we need better governance amongst ourselves around how we fund and how we support. And we can't be working in silos as departments, because we all rely on the amazing service providers that deliver, and without them, we know we are nothing. And so we want to make it a smoother, better path and provide better support. So acknowledge and absolutely agree with you that we have to work better collectively to better support our organizations. And in the early days, we're all very committed to that. And I will pass to my colleague, Ms. Lee.
Ms. Lee, I assume Emily LeBlanc?
Yes.
Okay, Ms. Lee.
Yeah, thanks for the question. And just to echo what Ms. Knight has said, certainly I think the Department of Community Services, I mentioned earlier a whole host of things that we've been able to do to support organizations like North End Community Health Centre, Adsum, and others who are working on the front lines in this work. And certainly the plan that was created a number of years ago, we are, by my colleague and friend who's next to me, our supportive housing approach, we had funding to create a target of 1,085 supportive housing units. And I mentioned earlier in my opening remarks, we've created 600 of those to date, so we're about a year ahead of schedule. That plan was created with partners like the Department of Municipal Affairs and Housing and programs like the Community Housing Acquisition Program in mind, as well as alignment with the Office of Addictions and Mental Health and the supports and programs that department offers. We've also, of course, done work with the Department of Health and Wellness in things like the bridge, which I'm hoping Ms. Lecker will be able to talk about in a few moments. Certainly, as Joy said, it really still is imperative for us to continue to break down departmental barriers and to continue to push from a whole of government perspective in terms of the work that we're doing to support the people that we serve. Individuals who are experiencing homelessness, my colleagues from Adsum and North End talked about they are humans, and frankly, they care not which department is funding the supports that they are able to access. And so it's really up to us to bring down those barriers, and certainly our Ms. Morren-Fraser, Ms. Knight, and I, among other leaders in other departments, work very closely together. We're chatting very, very regularly and are taking things like Ms. LeBlanc had said in terms of how we look at an organization from multiple department lenses at how we're funding and what we're funding together. Certainly we're doing that already through the Community Housing Acquisition Program and how it interacts with the Supportive Housing Action Plan, so infrastructure and then supports, and certainly moving into doing more
just
from health.
Secondly, so
That was it.
yeah, it's MLA LeBlanc. Thank you.
I'm
you.
sorry, I have such a little time. I want to ask about two things. Number one, Ms. Lecker, when you were talking about the number of children living in hotels, I mean, we support lots of families who are living in hotels right now, and I just, like, again, I can't even get my head around it. Is there any analysis on the cost of housing people in hotels versus the cost of building new, truly affordable, deeply affordable, rent-geared to income housing? And let's think broadly on this one for a second, because we think about like how traumatic that is for children who are changing schools and, in and out of different schools, and just that lack of stability and what happens to them down the road. So yeah, what analysis has been done on that? And yeah. Yes, sure.
Thank you, because I was about to ask her. Ms. Lecker.
I hope at some point you also ask me about the health outcomes for people who are living in hotels, aside from the cost. The cost is significant. I will tell you that we built 25 homes for one, two, and 3 bedroom apartments, many of them accessible and supported. And we put more than $2 million of our own money into that, along with $5 million from government. Right? So that's $7 million for 50 people housed. They moved in 2 years ago. They're all but one family still there. And I would say that we have the land, and we have the plans, and we have the professional team. If we could just have a bit more money, we're raising money on our own, but if we had more government money, we'd be building again. Tomorrow we'd start, and we'd be done in 18 months, because we did it in 18 months during COVID. Right, that's the Sunflower. And that housing is environmentally sustainable. It is beautiful, it is accessible, and it's permanent, and that's where rents are geared to people's income. So there you go. 50 people housed for, I don't know, $7 million, and that includes a community space and solar and everything. I think we also have to look at, we've really normalized what was an emergency response, which is hotels. And it made sense. I was around when, we started going around to visit hotel operators in this city at the start of COVID, and we were looking for extra space. But that's already a number of years ago. And we are seeing some people in hotels for 1, 2, in excess of 2 years, individuals and families. And there is a huge expense associated with that. There is, of course, the expense to the family and to the individuals who are impacted, but the children who are not meeting their developmental milestones because they can't crawl around on the floor and there's no place to cook and all of those things. But there's also a huge financial burden that is being covered by the government, right? So there's a lot of money being spent on emergencies, and I would argue that the CHAP program is great, but it's by and large a rooming house model. It's not for families, that's for sure. We've already knocked on that door. So we have to look at. I'll give a really good example, an actual one. So there's a family. I'm not going to give all their details, so I'm going to just kind of, because I don't have their permission. But let's say it was a large family. They needed 2 hotel rooms. 2 hotel rooms at $200 a night, including taxes and so on, came to about, I think it's $146,000 for a year. They were there for more than a year, but let's say it's $146,000. We found them an apartment. They are paying $14,400. We are paying, Adsum, not government, the remaining $19,200 for them to live in a 3-bedroom apartment. We just saved the government $146,000 for 1 year, and this family is together. We're fundraising the $19,200 to keep them housed. And we could do that with multiple families over multiple years. the amount of money, and I don't know, and I want to, I see Suzanne nodding, and Joy, I can look at Joy too. We've worked so closely on all of these issues, and what both of them have said is true. I mean, we are working with bureaucrats around the clock. There is no doubt that everybody is doing what they can. There are huge amounts of money involved in this, and a lot of figuring out by family, but also, of course, by system. You want to change the system. You don't want to just fix it for one family.
Sorry, order. Next will be the PC Caucus. MLA White.
Thank you. I was listening attentively. Sorry to cut you off. Well, my first couple questions are for Department of Community Services. We talk about housing on a continuum with homeless and sleeping rough on one end of the spectrum and home ownership or market rental on the other side. I'm just wondering if the department can tell us maybe how people reach from, tell us a little bit about the other points on the continuum and how their vision is that somebody may move along that continuum to ultimately home ownership if that's their goal.
I see Ms. Lee nodding. Ms. Lee?
Sure. I thank you for the question. I'm absolutely happy to start, and you may wish to hear from my colleagues with Adsum and North End as well. So we, as you mentioned, we talk a lot about homelessness and housing being on a continuum. We've heard terms like folks who are precariously housed, who might be doing things like couch surfing, individuals who might be sleeping in a tent, and then moving sort of from there through the system or through the continuum, I guess, would be things like emergency shelters. So we've heard about needing to respond to emergencies if people need a warm place to come in and have a place to stay. We have a number of service providers who are providing emergency shelters in a variety of models. In that kind of category of emergency supports is also where we fund, we call it the Shelter Diversion Program for families with children. As a rule, we don't support necessarily putting children into shelters, and so we are thankful for partners like Adsum who are able to support families with children in hotels until they're able to find a more suitable option. And moving kind of, you can't see the visual I can see in my head, but moving right to the right down the continuum, there's a new category that we've sort of been working on here in Nova Scotia over the last couple of years, in between emergency sheltering and what we call supportive housing. And we're calling it transitional housing, and that's really things like the bridge, which again, I hope Ms. Lecker has an opportunity to talk about, which is not quite an emergency shelter in the way that we are doing it in other places. It's a unique model with integrated services, and it's also things like the transitional shelter villages that we've created where we have single room occupancy units for people to be able to come in and have some dignity and some space of their own, which is kind of a step between a shelter and a faster to deploy between a shelter and supportive housing, and supportive housing for us is all of the housing programs that both Ms. Lecker and Ms. LeBlanc talked about in terms of the portfolio of projects they and other service providers have for folks who have been experiencing homelessness. And there are many, many models in that category that we support, some for low acuity where people might just need a bit of support to stay housed until they're able to find an affordable apartment, for instance, or as Ms. LeBlanc mentioned, things like the Overlook, which is a much more sort of intense wraparound support approach to supportive housing. And I will say in all of that and in the work we do, balancing the need for emergency response and the need for long-term investments in things like supportive housing, it's a continual conversation, and we support the discussion around families with children and how we move them along the housing continuum into something more long-term. And we've got a number of projects we're excited about with Adsum that I'm hoping we can tell you about in a couple of of weeks. The other piece that I would say about the continuum, and feel free to stop me, I will keep going, is it is not a linear path for folks. We know that people who are experiencing homelessness, they're human beings, and everybody's experience is unique, and everybody's experience through the continuum is unique. So you may have people kind of moving in and out at different phases, requiring different supports depending on a life event, for instance. And really what we want to be able to do is provide a range of options to give the supports that a person needs wherever they are in their life and in their experience. So maybe I'll end there.
Emily White, you want anything else? Anybody else?
I got from that you're meeting where they're at.
Okay, Emily White.
Perfect, thank you. This is a lot. It is a lot for sure. But it is a big topic we're talking about. It really is. And we're talking about from homelessness to market rentals or home ownership. There's a lot in between. And I appreciate that's a big challenge. Something else we heard about today is the rising cost of living. And I know that's not just in the city, it's not even this province, it's this nation. So I'm just wondering if you can tell us a little more about what the department is doing to help Nova Scotians who are struggling with rising cost of living, because that really is leading to a lot of the issues we're facing.
Miss Lee again, I'm assuming she's smiling.
Thank you for the question. And I have the great privilege of not only being responsible for the department's response to homelessness and supportive housing, I also lead the program area of employment supports and income assistance. So we, in my own shop, we have some tools to help with the affordability for some Nova Scotians who are eligible for income assistance and employment supports. And certainly this year, you would have seen increases to income assistance through indexing, an increase of $300 to approximately 60% of the caseload who are eligible for a disability supplement. And there are broader affordability conversations and work happening across government that will have an impact on Nova Scotians beyond DCS's clients. Certainly things like the school lunch program and some of the food programming that we know we are funding, as well as other organizations or other departments, that providing supports for food instability, taking the question of how am I going to pay for my child's lunch, being able to do some of those things for families will have an impact. Certainly, we are also looking at things like digital inclusion and how we can support Nova Scotians with one of the major social determinants of health that we know, being connected to digital tools, being able to connect to a number of government and other service providers who are increasingly moving services online, being able to make sure that all of the Nova Scotians that we represent are able to make that connection as well. We know lots of other programs that other departments are doing. I won't speak to all of them because they're certainly not my area of expertise, but we absolutely have an eye to those programs to make sure that as we are thinking about affordability and the programs that we run at the Department of Community Services, that we're considering impact. So things like, and certainly Ms. Morren-Fraser could talk more about the rent supplement program, the official title of which I've just forgotten, the Heat and Heart program from Service Nova Scotia, Seniors Care Grant, and some of those other important pieces. While they're not run by DCS, of course, they're a critical piece for us.
Emily White.
Thank you. Before I pass it to MLA Young, I would also say I'm particularly happy with the increase in earned income exemption and the training allowance to be considered as earned income. That is meeting people right where they're at and trying to help move them forward, because that is a safety net that they're using. But thank you for your answers. MLA Young, please.
MLA Young with 11 and a half minutes left.
Yeah, perfect. Thank you, Chair. I'll direct my questions to Department of Community Services. You've been doing this for several years, and I'm sure you've learned a lot along the way. Just curious, maybe you could explain what you're doing differently now compared to perhaps even 2 years ago.
Ms. Lee.
Sure. So thanks Thank you for that question. I personally have only been doing this now for 8 months. My colleague Joy Knight to the right has been doing it a bit longer, or was doing it a bit longer before I arrived. And so I'll speak to some of the things that actually Joy implemented. But certainly, I mentioned in my opening remarks, one of the things we rely on almost the most, I would say, in the work that we do at Community Services on homelessness is listening to our partners like Ms. LeBlanc and Ms. Lecker on how context is evolving and how we can rise to the occasion and meet them where they are in terms of the solution that they're trying to provide. So while again, I will put a plug in for Ms. LeBlanc to talk about the bridge. It is one of the ways that we've evolved in our work. So a number of years ago, it was identified an increased need for an integrated approach to a shelter with health services and other services on site, to determine how that would impact people's outcomes. And certainly I would look to my colleague, Ms. LeBlanc, to talk about the bridge and what it looks like today, and lots of other kind of examples of how we've evolved. I mentioned the transitional housing sort of category with pallet villages, things that are easier to deploy, faster to deploy, while we're also trying to build support organizations to build housing. And really it comes down to every single project, every single conversation we're having. I think the department and our staff learn something new, and our program and our funding is flexible, that we can meet most times the ask in terms of a project that comes up. So that's how things like the bridge, things like the shelter villages and other pieces have been able to come to fruition. Would you like to hear from Ms.?
I got a couple of questions.
MLA Young.
Just back at, we got extreme heat, we got extreme cold here in the province. What's the plan? What's it look like?
Ms. Lee.
Thanks for the question. So our team has an emergency weather response team and protocol. So whenever we get an alert, we have a connection with the emergency management office. Whenever we get an alert that there is potential weather coming, we have a number of organizations that we activate across the province to do things like open up additional shelter capacity. We know that on a day-to-day basis, not everybody is able or willing or wants to access a shelter, for instance, in their community, but often if there's an extreme weather event, we'll do more to encourage folks to come in. And so we have a list of organizations that will stand up additional capacity in a very short amount of time. And we do that whether it's there's some criteria, if it's a big snowstorm, for instance. If it's very hot, then we might do that, and we might also send service providers out with additional water and things like that. We are always looking, kind of forecasting and planning out what projects we might need to bring online. So we're already thinking now about what winter will look like and whether we need additional capacity beyond what we have in place for the winter. So all of that kind of work is happening now. And we got an alert this morning that there's a potential hurricane potentially making its way to Nova Scotia. So the team is already starting to think about if that starts to track what are our plans to be ready.
MLA Young.
Thank you, Mr. Chair. Just as you mentioned winter's coming. What are you doing to prepare to get ready for winter now?
Ms. Lee.
Thanks for the question. So essentially, I mentioned some of the work that we do in terms of the emergency weather response, being able to activate and make sure that all of our service providers who are in that group have the tools that they need. We also, I mentioned, are working now on assessing capacity indoors for winter, what we have coming online for supportive housing, transitional housing, and other pieces between now and October, for instance. We are also always looking at properties to assess them, whether they're useful for supportive housing, transitional housing, or shelter. So winter shelter, of course, is one of those things now that is sort of top of mind as our team is out looking and assessing properties. Whether that is, a year or a season-long shelter or something that we can stand up and stand down, that's the type of planning that is happening now.
Emily Young.
Yeah, thank you, Ms. Lee. I'll pass it on to my colleague, Emily Palmer.
Emily Palmer with 5 minutes, 40 seconds.
Okay, thank you, Mr. Chair. Well, this is a great conversation. Thank you for being here this afternoon. Ms. LeBlanc, Ms. Lecker, thank you for the work you're doing in your organizations, and to all the department staff who are here today. It's I think, encouraging for people who might be watching, Nova Scotians, to know there is great dialogue happening between service providers in our communities and our government departments in trying to find those solutions as we're working towards better outcomes for sure. We've heard from your organizations, and I just want to highlight a couple in my area in the Annapolis Valley. I know there were some recent investments in some attempts with the Valley Roots Housing Association, the Portal Youth. I mean, a lot of people know the great work they do in those wraparound health services. There were some recent investments. I just have some information here. 16 new supportive housing units for individuals in the Waterville area, more in Kentville. So I guess I'd like to ask, maybe I'll ask Ms. Lee if you could comment on those and just talk about the partnerships that work really well for Nova Scotians, and so they can know that there's a lot of, I guess, advances and outcomes improving. Ms. Lee.
Great, thank you for that question. And the list of projects in Kentville and in the Annapolis Valley area, we do have a number of really amazing partners down there. And you missed one, Open Arms, who we've been working with on a number of projects. And one of them is a shelter village that is opening, I understand, imminently in Kings County, just outside of Kentville. And we've talked a lot about today HRM and the service providers certainly that represent the HRM, and there are many others in HRM that aren't here today, and there are many others in other parts of Nova Scotia that we work really closely with. I believe there's a list of 26 organizations at this point that are in this work with us, and certainly when we talk about things like data challenges earlier today, it really is those organizations that are on the ground that understand the needs of the community, where people are. When we talked earlier about meeting people where they are, it really is those organizations who know what those needs are, and they are the ones that are informing us in terms of where investments could be and how we can support folks. Certainly in the Valley with the projects that you mentioned and a few others that we know that are coming online, we actually think the Valley will be in a very good position coming into the winter. It will never predict to solve homelessness, but certainly, good progress is being made there, and we're really encouraged by the work that our service providers are doing. And we know similar work is happening in many other places. We talked about the Ally Center and New Dawn, Cape Breton Community Housing Association, lots of other organizations in other parts of the province that, again, are as great as Ms. Lecker and Ms. LeBlanc in terms of the work they're doing.
Emily Palmer.
Thank you for that. Because the numbers we're suggesting of developments for people getting housed, they're not insignificant numbers for areas in rural Nova Scotia. So I appreciate the work that's being happening there, and did not want to slight Open Arms because they do an amazing job, and Project Hope, another organization trying to connect people to housing. So there's some great organizations out there. I just want to switch gears maybe to Ms. Knight in the Department of Health and Wellness. People in our province, for circumstances, we don't know what those circumstances are, but move from one place to another. Maybe access to primary care because of those moves might be a little more challenging. Can you talk about some of the developments and some of the things that we've been doing as a government over the last few years with things like virtual care, maybe primary care, pharmacy clinics, just which help people in those moves have access to primary care. If you could discuss that, I'd appreciate it.
Ms. Knight with 1 minute, 20 seconds.
Thank you for the question. Yeah, there's been a number of initiatives over the last couple of years to increase access to primary health care. And as I mentioned in my opening remarks, we're looking to continue to expand and push that envelope with the health home and health neighborhood model and ensuring that people have access to the right care in the way that they need to receive it. And so there are a number of new initiatives in place and expansion of existing in really meaningful ways across the province. So there's the collaborative family practice teams. We now have 107 across the province. You mentioned virtual care. Those numbers are significantly growing, actually, in use, for particularly people who aren't attached to a primary care practice at this time. One of the great statistics that we're seeing out of access to virtual care is it significantly reduced the number of visits to emergency departments for people who are not attached to a physician because they are being attached to the services that they need. Emergency departments where they would have gone in the past because they didn't have other avenues to access the services they needed. We've got a number of mobile primary care clinics around the province offering, just as in May, over 2,000 patient visits. The primary care clinic's an excellent example of how a new model has come into being to ensure we have access for people on the Need Family Practice Registry.
Order.
Thank you.
The next round will be 8 minutes, starting with MLA Clark. MLA Clark.
Thank you, Mr. Chair. Thank you, everyone, for being here today. I would say, listening to this over the last hour, 20 minutes or so, I don't want to speak for Ms. Lecker or Ms. LeBlanc, but I think what I've heard is that one of the main barriers to continuing and expanding the work that you're doing is core funding and consistency and stability. And that's an issue that we hear from nonprofit groups in all sectors all across the province, and dealing with 30 contracts is an administrative nightmare beyond belief. So I was just thinking about this during the last round of questions, but one of the things that's come up in some housing legislation recently is the idea of a trusted partner program for developers, which I actually think is a good idea. Because if you've been building housing in Nova Scotia for 50 years and you've got a great track record, maybe it should be easier for you to move through the process than someone who started yesterday, for example. So when you think about the work that North End Community Health Centre and Adsum are doing, again, you're not the new kids on the block. You've been around for 40, 50 years. So this is a question for either Ms. Lee or Ms. Knight, perhaps, but I know we've touched earlier about the need for core funding, but does something of that nature, a trusted part, obviously these organizations are trusted partners. It's something the government has endorsed for private developers who have a track record. Why would we not pursue a similar model for nonprofit organizations that have identified today how critical that stability and core funding is? And they are trusted partners, I think it's safe to say. So what would be the impediment to doing that, I guess?
Ms. Lee, since she seems to be whispering in your ear.
Sorry, thank you for the question. I think what the link I'm trying to make is between is the example. They're sort of different contexts, I think, in terms of the funding that a developer would get doesn't necessarily align with the funding that the Department of Community Services provides for something like a shelter or a supportive housing unit, where we would fund. For instance, if a supportive housing building was being created, we don't necessarily fund the infrastructure. I would look to my colleague to speak about that. But from a unit perspective, and the cost to run the organization, to support the operations of the organization, we would fund sort of all of the elements identified in there with things like staffing and supplies and that sort of thing. So there is a bit of a nuance for us in terms of the mandate we have in terms of funding is not necessarily funding organizations. We're funding the types of we're funding projects, essentially. What I think we talked about earlier that I think we can do better across government.
Just 1 sec. MLA Clark.
Thank you, Mr. Chair. And apologies, Ms. Lee. I just have probably 5 minutes now. So
4:40.
4:40? Close. My point, I understand that it's not apples to apples exactly, workshopping this on the fly. But I think my point is that I think there's a concept that the government has acknowledged on the private development side that, if you're a Shaw or if you're a Crusco or somebody who's built thousands and thousands of homes in HRM, you are trusted, and the paperwork and the red tape that might exist for somebody coming in, today should be less. So that's my point, is that I think, and I'll direct this perhaps to Ms. Lecker and Ms. LeBlanc, if what I'm saying makes sense to you, I think, could you just describe for us what's the value of having that consistency and simplicity, and what is the detriment right now of having to deal with, for example, 30 contracts and just the administrative pull versus the actual work that you're meant to do and that you want to do with most of your time, I'm sure.
So MLA Clerk, which one do you want? Because
Ms. LeBlanc,
Ms. LeBlanc.
Start.
Okay, 3:30.
I actually get the link that you were trying to make, and I think that the key thing is that we don't think in silos. I don't think of, oh, this is a health issue, and this is a housing issue, and this is an issue. And unfortunately, to get any solutions, that's how the government thinks. So to your point, you only fund projects. To solve this problem, we've got to get away from that. It's not a project. It's a full spectrum. And whether it should be, in my humble opinion, it should be an issue of homelessness. And what do we need for that? And we don't need to go to health for one thing and for another, because back to even metrics, primary health care asks me for metrics on one thing. That has nothing to do with homelessness, but those are the people that I'm treating. DCS asks me for metrics on something else from my clinic, which is completely geared to health because that's what health wants. It is an absolute nightmare. And it's not looking at the issue as a whole. It's looking at it from government department perspectives as opposed to from the people perspective and what they need in order to solve this issue, which in fact is what we need in order to help them solve that issue. So I have 30 buckets and not one of them pays for me. Not one of them pays for my director of housing, my director of mental health and addictions, my finance director, who has to manage 30 buckets of money, my HR director that has to manage 180 people. None of those things are paid for. Plus, not a single one of my contracts actually, I have one contract for a managed alcohol program, which is the same amount year after year for 3 years. Has anyone looked at the cost of alcohol? Has anyone looked at the cost of gas for the car that's going to it? I mean, none of those are static costs, and I'm still expected to support the exact same number of people. So who's paying for that difference right now? Who's paying for the difference in the cost of oil and all that? So none of these things are taken into consideration as real life issues. They're little projects, and leaving it to the not-for-profit to figure that out. So to your point, if we had a way of looking at it as in, here's the solution, how do we all work together? And we're not looking at it from, I need to get this from health, and I need to get this, and I need to get that. Because in some cases, projects are approved by one department, and when they go to get the money from another department, they don't approve it. But we've already started. We've hired the people, and now we're being told it's not happening. This happens on a regular basis as well. So it's very complicated, and the system's just not built for that. And Sheri, I think, wanted to add something.
Ms. Lecker, 41 seconds.
Okay. I would only, I'd say ditto. Programs don't come with, that's not an all-encompassing solution. So I particularly looked to the Department of Health, Department of Housing. They have a great chat program, but it's really a rooming house model. It doesn't work for families. That's an example. But there are things at the bridge, and I haven't had an opportunity to speak about the bridge, but there are health needs that we are paying for with our own funds because our health partner doesn't have funds for it, and it's not in the budget anywhere. But we need to provide those things. So if people need foot care, we're paying for foot care, even though there are health services available, but they don't include foot care. So
Order. Sorry. MLA Burrows.
Thank you, Ms. Lecker. Would you like to complete your thought?
Ms. Lecker.
Sure. I was just going to say that there are many things in the needs of individuals and families that we can't even imagine until we're working with people, right? Everyone around this table has different needs. Your households have different needs. And while we're working to end someone's experience of homelessness and support them, they have many different levels of acuity and need, and we have to meet them. So if somebody needs Ensure, we have to buy it, but it's not in the health budget. It's not in the shelter budget. We just pay for it. Thank you.
Emily Burrell.
Thank you. Ms. Morren-Fraser, I wanted to come back to this key idea that Ms. Lecker has raised about pathways to homelessness. So we know that a key central pathway to homelessness, of course, is the price of rent, particularly in Nova Scotia. We know our rent has gone up in the last year more than any other part of the country. So when Food Banks Canada looked at this recently, one of the things they recommended had to do with this important subject Ms. Lee brought up earlier, the rent supplement program. They said an awful lot of suffering related to rent and housing has been caused by that transition by which we went from that you no longer were eligible with 30% of your cost being related to rent. It had to be 50% in order to be eligible. They said if we want to put it in this language, block this pathway. Then we need to restore the eligibility for the rent supplement as it was before the government made that transition. So I want to ask you, is the department alive to the real suffering that has been caused by that transition from 30% to 50%? And is some consideration being given to reestablishing the eligibility for the rent supplement program, so important for the people that we're talking about, as it was before that change?
Ms. Morren-Fraser.
So thank you for the question. And I will start by saying that the department is very much, particularly the staff that work day in, day out with the folks who are accessing the program, very much alive to the challenges that folks face and how the rent supplement program is being used to reduce housing need. We're constantly reviewing our programs. That's one of the things I'm most proud of working at this department. Is it really, I can say, is a continuous improvement environment. And so that is amongst all the range of pieces that we're looking at, for sure, to look at what is the impact of programs now, programs as they've evolved, and do we need to make additional adjustments? And I think we've demonstrated that we do make changes when it's needed. We've just recently made changes to the program for secondary suites, for example. With respect to the change on eligibility to the program, I just want to clarify that it didn't take away subsidy from people who already had it. It was about going forward to ensure that the resources were directed to those in deepest housing need. So it was really about making sure and looking at how do we ensure that this program that is targeted to those in housing need serves those in the deepest housing need. So that was the thinking behind that change. Certainly wasn't in any way, shape, or form intended to create hardship for anybody already in receipt of a rent supplement. But I can assure you that, yes, that is certainly one of the things that we're looking at as we look at all of our programs to see if they're having the intended impact. And as we hear, as our staff hear daily from folks who are applying, and we recognize the very difficult situations that people are in, what can we do with the policy levers and programs and resources available to us to serve as many people as possible, to meet them where they're at, to help them with regard to their housing.
Emily Burrell.
Well, I think it's maybe it's not too much to say. It's not pathways to homelessness. It's highways to homelessness in the current situation. That we got the report last week. Rents went up in Nova Scotia last year 18%. We know from your own department's internal analyses that in units where there has been a change in tenancies, the average increase is 28% over a year. That's because our rent control does not cover new tenancies as it does in other jurisdictions. So So I want to ask: does the department acknowledge? Do you acknowledge? And in the world of your work, is it acknowledged that having a rent cap which excludes new tenancies is in fact having the effect of making rent so beyond the reach of many low and medium income earners that it is in fact opening up a barn door to homelessness in the province?
Ms. Morren-Fraser.
So I will start by saying that the legislative responsibility for the rent cap is with the Minister of Service Nova Scotia under the residential tenancy, so I can't speak to the policy decisions that were made, and I certainly can't speak to government's decision on that. I will leave that to government officials to speak to that. What I can say is that I was very much involved in supporting the Housing Commission that was in place at the time, and there was a lot of debate around the table of the folks that represented sectors across the province and various organizations about it, and there was a lot of research done across the country that went into recommendations and considerations that were put forward, and the Commission itself I believe recommended that it be continued as an interim measure, not as a long-term permanent measure. So that's what I can say from my observation at that table, was that it was recognized as something that should be pursued at interim, while other measures were taken that they had recommended in their full list of recommendations to try to improve affordability in other ways, to get more supply to market more quickly, and to work with organizations across the province, across sectors, to do that. So that's sort of what I know, what I observe, and I would say more specific questions about how, what's happened as a result of the implementation and where government plans to go would be for others to say.
MLA Burrow with 56 seconds.
Well, you have identified, Mr. Lecker and Ms. LeBlanc, the pathways to homelessness. You talked about fixed-term leases, renovictions, rents that are too high. Would you say what on those areas do you recommend to block these pathways off?
Emily Burrow, was that to Ms. Lecker or Ms. Ms. Lecker?
Yeah.
Thank you for the question. I would say tying the rent cap to the unit as opposed to the individual would be really, really helpful. I would also mention we do one-time payments through a program. Last year, that one-time payment prevented more than 500 people from becoming homeless. That's managed by one staff, money from government, and money that we fundraised. So a one-time payment at the right time, not just for rent, but maybe for utilities or anything, can make a huge difference in preventing, I think it was 533 people from losing their housing. So we have to look at ways to stop.
Sorry. Emily Palmer.
Thank you. I just have one more quick question, and I'd like to go back to Ms. Knight to maybe have a conversation around how the Department of Health and Wellness, from your experience with community services and now with health and wellness, you talked earlier about some of the things you'd like to bring to the conversation and understanding the system gaps and addressing them from a health and wellness perspective. And obviously we've had conversation. We understand that those who are homeless or inadequately housed face unique needs in their health care services and what they need. So can you just, again, maybe go back to the conversation and talk about what we're doing different now as things we've learned as a department going forward and what we've learned from the past and how we're doing things different to address the system gaps that might exist in all these silos that are out there, and have a conversation about that, please.
Ms. Knight.
Thanks for the question. I think there's a number of things we've learned, and like my colleague, I haven't been in this position for the full 2 years, but I can speak from the experiences I had previous and to where I am now. There's certainly a difference in how we think about having more than one access point and not in more than one type of service. One type of service can't meet the needs of everybody. And so how do we more customize and tailor services to better meet the needs? And how do we learn more from community around what the right services should be? So I think if I could take a moment to talk about the bridge, in the that being a very different new way of thinking about how we provide healthcare supports to this population. And it's not just about providing the supports with a service provider who completely, fully understands their needs and able to meet them where they are. It's having really important impacts on the healthcare system more broadly. So ED avoidance is a really positive outcome. So better outcomes of the people that live there, but it also is reducing pressures on the system. So less people are actually accessing emergency departments because they can get their services there. There's infectious disease clinics that are happening on site, supported by Mosh and Dr. Hughes on site there. That's keeping people from having to come in for inpatient care or into emergency departments for care. So that's a really different way of thinking about how we deliver healthcare services. Instead of asking you to come to us, we are figuring out ways to come to you. And I think that's a significant shift and lots of opportunity to take that model. My hope is outside of HRM and think about how our other communities are able to benefit from that type of thinking and access.
MLA Palmer.
Thank you very much, and thank you all again for coming. I'll pass it on to my colleague.
MLA McLeod.
Thank you, Mr. Chair, and thank you, directors, for making time to be here. My question will be directed to Ms. Morren-Fraser, and it has to do with the 5-year housing plan. Today we've established that housing is a social determinant of health. How is the 5-year housing plan going? How's the progress going? Where are we at with that?
Ms. Morren-Fraser.
Thank you for the question. So we're not quite a year into our 5-year housing plan. It was released in October, and as folks might remember, we had 3 key pillars that we're advancing, focusing on creating the conditions with partners to create new supply, to grow and sustain affordable housing, and to make sure that we're providing programs that people need. And so one of the core areas that we're looking at is how do we get more supply more quickly to market. We've all talked about today the importance of having units for folks to go to at prices they can afford. So one of the things, of course, that has been a great achievement is we're starting work on 273 new public housing buildings. So a number of times today it's come up that what we really need is rent geared to income units. Those will be rent geared to income units, and they will house over 700 low-income Nova Scotians. We also launched the new backyard and secondary suite, which is one of the best tools that we have at our disposal to use existing properties, existing land to add density. So far, since launching the program, we've approved 190 applications. So that's 190 new units of housing for folks. Last year, just for an example, working with our partners primarily in the community housing sector, we contributed to the creation of 276 new units that will be offered at affordable rental rates. And just last week, we announced changes that are coming to the short-term rental regulations that will hopefully incentivize commercial short-term rentals to convert to long-term housing. So there's over 7,000 of those registered in the province now. We're hoping that a number of those will convert into long-term housing, creating more of that stock. We know all of this takes time, so we know people need affordable housing, so we are also investing in our rent supplement program that came up. We're adding 500 subsidies this year. We'll have 8,500 in total by the end of the year. And just recently, we also launched a new stream under that specific to women and their families fleeing domestic violence. So we are creating a new pathway with our community partners who are going to refer eligible individuals to that stream, to the program, to make sure that they get rent supplements as quickly as possible. I will just mention, too, that we partner closely with Community Services on a stream of our rent supplement program dedicated to those experiencing homelessness, who work with housing support workers to make sure they're prioritized to the top of the line. And we do the same thing in public housing to make sure that those folks who are experiencing homelessness are prioritized to the top of the line. The last thing I'll just mention that is a significant piece for us is we know that we need to preserve existing affordable housing. It's one thing to create more, but if we lose the existing housing that's affordable for folks, we're not going to be further ahead. So we invested last year to help almost 3,000 low-income homeowners in Nova Scotia to stay in their homes rather than having to leave and put pressure on the rental market by being able to complete needed health and safety repairs. So really working on making sure that we're helping the existing affordable housing, creating new supply, And as much as possible, we're making those affordability supports available to those who can't afford the housing that they may already have access to or that they could afford with just a little bit more help.
Emily McLeod with a minute, 10 seconds.
Thank you, Mr. Chair. You know, we've heard the term silo here. I was curious, your Department of Municipal Affairs and Housing, how do you work with DCS and the Department of Health to support people who are experiencing housing insecurity? How does that work?
Ms. Morren-Fraser.
Thank you for the question. So we work very closely. So we all have program teams who work, I would say, daily together to make sure that they're connecting on the shared clients. We have a number of shared clients, particularly those in receipt of income assistance. So making sure that the income assistance caseworkers are connected to public housing support workers, to our rent supplement program, to make sure they get placed for those who have housing support workers, that they are being placed at the top of the queue to get a rent supplement or into public housing. But we also work on what's been mentioned, the program, Community Housing Acquisition Program, or CHAP as we call it. It isn't just a rooming house program, I'll mention, although I think that may be...
Sorry, that concludes the time for questioning. We'll now go to closing comments. I will start from my right to my left. So, Ms. Lecker, do you have any closing comments?
I do, thank you.
Ms. Lecker.
I do, thank you. Thank you again for the opportunity to speak today. There is no question not having safe, affordable housing is detrimental to health outcomes for our whole community. We need to close the pathways that are leading to housing insecurity and creating conditions where people can live safely, securely, with dignity, and improved health outcomes. This is not possible when we allow people to live 40 to 65% below the poverty line, which we have not really discussed today. Studies show that people who experience homelessness have a reduced life expectancy. A study published just last week in Toronto found that without safe, stable housing, people live 17 years less than their housed neighbors. That's the link to health outcomes. We all know this, and we need to take immediate, historic steps to make this a reality, to make a change for Nova Scotians. Thank you.
Thank you. Ms. LeBlanc.
I don't have any formal statement, but at the North End Community Health Centre, we were formed 52 years ago based on the social determinants of health. These are not new. We've known that the way to support those experiencing homelessness and deep poverty is through this integrative collaborative model. Our funding and our supports are not integrated. They're not done as they're done in silos. I understand that the departments all work together, but the thought process and the implementation is not done. Housing needs to come first. It needs to be supported by all of the other things that we've been talking about. In order to tackle this problem, which is homelessness and health, together, we need to do it together as a team, one approach, not 30 different buckets of money. Thank you.
Thank you. Ms. Lee.
Thank you. I also don't have prepared remarks, but wanted to take the opportunity to thank again the teams, my team and the teams behind all of us who are doing the work represented at this table, and the many other service providers who are doing the work. I think loud and clear, we've talked a lot today about how government departments are and need to do better at working together and supporting the organizations who are doing this work and seeing what is needed on the front line. And certainly we've done our best and will continue to work together on this really important piece. Thank you.
And I shouldn't have skipped over to see if Mrs. Morren-Fraser needed anything. My two left and right reminded me that. So, Ms. Morren-Fraser.
Thank you for the opportunity. So yes, I would just like to echo my colleagues, and I just want to say what strikes me is we all have a shared objective. We are working towards the same thing. We are very much aware of the system integration that's needed, and we are actively working on it, and I think that's what gives me hope, that We're asking really good questions of each other. We're learning from folks on the ground. The departments are working together, and while this is an extremely complex issue and there are people who are in desperate need of support, it gives me hope that we're having this conversation today and the recognition that we need to do things differently, and things are rolling out to do just that. So I walk away today with hope that we will continue the good work that we're doing to work together.
Thank you. Apologies again. And lastly, Ms. Knight.
Thank you, and thanks for the very thoughtful questions today and discussion. I'll just reiterate the commitment from the Department of Health and Wellness that we are here to be partners for the long term. Thank you.
Thank you. That'll conclude the part. We do have some business, but I'm going to take a 3-minute recess just for the witnesses to be able to get there. So we're in recess for 3 minutes. Order. Okay, so I called the meeting back to order. I'm going to deal with correspondence. On July 11th, 2024, email from Department of Health and Wellness, following up on the July 9th meeting with a link of a video promoting the province's colon cancer screening program. Everybody saw it? Right. Okay, so the next business is I will turn the floor over to MLA Burrell.
Thank you, Mr. Chair. I'd like to make the following motion. Whereas housing precarity and homelessness have a direct negative impact on people's health and wellness, and whereas so much homelessness is being caused by the government's abetting of landlords' misuse of fixed-term leases as a way to evict tenants and get around the rent cap, and whereas one reason the numbers of homeless people are increasing so sharply is the dramatic rise in rents enabled by a rent cap that excludes new tenants, therefore, the Standing Committee on Health calls on the government, in light of the information that has been presented this afternoon, to review and reevaluate its approach to these policies on housing.
Do you want to speak to it, or just the motion because it's your motion?
I move it.
Okay. Is there any discussion on the motion? Okay, MLA Palmer. Oh, who did I miss? Okay, thank you. Emily Palmer.
Okay. Thanks, Mr. Chair. So I'm not exactly 100% sure what's being asked in the motion, 100%, calling on the government. But I think what we've heard this afternoon is all three of these departments and the partners already agreeing to evaluate and reevaluate what's going on. Ms. Knight talked a lot in her presentation about continuously working to do different things and get better outcomes. So I'm really not sure what the motion is really asking, to be honest with you. So at this point, it's not clear enough for me to decide to vote on it.
Okay, Emily LeBlanc.
Well, thank you, Mr. Chair. I mean, I would agree that with Mr. Palmer that we did hear that from the folks working in departments, but we also heard from people working on the front lines that we are in an emergency situation. And we have been for quite a while, but it is getting worse and worse. We heard from Ms. Lecker that 43 to 67% of people are people are living 43 to 67% below the poverty line. That is an emergency situation, and it's all fine and good for departments to be speaking to each other. And and one of the things that I thought about when I was listening to that today is that's really good to be doing, in a non-crisis situation. But in a crisis situation, we need to stop talking. We need to start acting. And so this motion suggests that, in my opinion.
Any other discussion? MLA White.
Thank you, Chair. I have your motion in my hand here, and I'm reading through it several times, and I'm having trouble understanding some of it, to be honest with you. Not the point of it. I get the point of it. I get that, but I don't recall. I think it says here. I thought it said here that the rent cap is noted as causing a great increase in homelessness, and I don't recall them talking about that much, to be honest with you. So, I don't want to just deny your motion just for the sake of denying it, but I would like to review the meeting today before I vote on this, to be honest with you, because I don't know if I don't recall the information off the top of my head to say that it supports what you're saying in this motion.
Emily LeBlanc.
Is there a way to move to adjourn and so keep the motion on the table so that we can do just that? We can have our colleagues review the motion and we can bring it back next meeting?
So it would be in order to call for a motion to adjourn. I do want to thank MLA Burrell for having that emailed out to everybody. That's in order. And then this would sit on the paper for the next meeting. So if somebody wants to do that or talk for the next minute and a half. Or I'm being told you could formally move to have it considered at the next meeting. So it's what your wish is.
Question and recorded vote.
Okay, so no other debate, and you're calling for a recorded vote. So everybody ready for the vote? Okay, we'll call for the vote. The clerk will do the vote, and you'll be calling everybody. I don't have to do anything, right? Other than vote? Okay.
All I have to do is call out. All right. MLA McLeod. Yes or no?
No.
MLA Palmer.
For the reasons I've stated, no.
MLA White.
No.
MLA Young.
No.
MLA Clark.
Yes.
MLA DiCostanzo.
Yes.
MLA Burrow.
Yes.
MLA LeBlanc.
Yes?
And MLA McDonald.
No. So the motion has defeated. And is there any other business? Okay, so our next meeting is Tuesday, September 10th, as the House is sitting. It will be 9 a.m. to 11 a.m. Promoting physical activity, witnesses, Healthy Tomorrow Foundation, Department of Community, Culture, Tourism, and Heritage. We are adjourned.
Thank you.